Welcome to the 8 Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back to the 8 Minute Rule. We've got Mark, Lucas, and Drew. Got the whole gang here back together again. What we want to talk today about is more specifically just strategies around identifying specific tissues and how that's going to drive your treatment to some degree. So first things first, my youngest started kindergarten today. So our icebreaker question: what was your favorite elementary school subject? Start with you, Mark.
I mean, and PE does not count. Is that what we're saying?
Yeah, we'll go second to PE for all of
All
us.
right. All right.
If they still have PE,
I guess they were right. I guess they were very general back in the day, and it was like science, right? And I would just say science was my favorite.
Like it. How about you, Lucas?
Yeah, it was science. Yeah, it was science. No,
This was
no,
science.
no reading. I never liked reading languages. We have to learn two different languages, and I never liked.
It served you well, a lot better than it did for us. That's for sure.
Oh, I'm laughing because I'm the same way. I was not a fan of language arts or English, I think is what we had called it at the time. But yeah,
Right.
science was my jam. It still probably is.
I think
So
that's a clean sweep for all of us.
here's a fun one of all of that. So in Brazil, follow the same calendar of European schools. So from first grade up, we have 6 discipline every day, 5 days a week, which is it was science, it was history, geography, languages. So like the whole year. It's
Very
just
nice.
crazy.
All right, so moving on. Guys, we want to talk a little bit today about, as I talked about at this onset, just kind of as we're looking at different types of structures, different types of tissues, how is that going to influence, one, our evaluation, and then as we're going to filter into the treatment as well too. So, a little bit of a vague category here, but Mark, go ahead and give me a rundown of what you got off the top of your head as you're thinking through this.
Well, I'll give you a patient case that I have currently that I was working through a couple weeks ago. It's an athlete had confirmed cam deformity in the hip via X-ray, and then followed up with an MRI, and was having some like deep groin pain. And I was like, that's a little bit unusual for a cam deformity. Not that it's unheard of, but it kind of matched with the theme that you would expect. Like deep squats were painful, lunges were painful at the end range of it. Basically, deeper hip flexion activities. And so I was like, okay, I tested it out, and I was doing all the hip tests, like, passive, internal and external rotation, joint play. And don't get me wrong, this guy has very stiff hip, but none of it reproduced his familiar pain. So like, this is weird. And in the subjective, I had asked him like, hey, do you think this is what's going on? And he's like, no, I think it's something else. Like, all right. So that further reinforced my desire to dig a little bit deeper. And all I did was put my fist in between his knees when he was hook lying, and he squeezed my fist, and immediate reproduction of his familiar symptoms. And I was like, okay, well, he has a stiff hip for sure, but this is a contractile structure that I'm working with here. Like, that immediately reproduced his symptoms. And when you think about it, hip adductors assist with hip flexion when you get in greater degrees of hip flexion. And so it tracks that it manifested in the way that it was. We did a little bit of Copenhagen eccentrics, and it was like an immediate 50% reduction with just 10 reps. And so we did another couple sets and got even further improvement from it. And so, to your point, if I had just stuck with what I was told and what the imaging had shown, I probably would have gone with the hip mobility exercise, and maybe it would have helped. And don't get me wrong, he needs some more mobility in his hips, but it would not have had that drastic of an impact day one.
Yeah, that's a huge, huge thing. Many of us are going to get some imaging before we see patients. As they bring it in, they're going to be very stuck on, here's what my imaging says. And so I think being able to navigate those two things, between using that as a piece of information, but almost kind of blinding yourself to that a little bit at the start, and making sure that you're going to use your clinical diagnosis as well too, to either match or push you another way. So very cool. Drew, what you got, man?
Well, I was just thinking on that similar note where the imaging really often gives us like a very specific type of structure. And at least in the PT world, we have often got away from super specific structural diagnoses, whether it's a specific rotator cuff, whether it's something specific in the hip, and it's a little more general. And I think that's a very good thing, but you also have to match that with knowing what type of structure you're treating. So what is it contractile? Is it non-contractile? Is it internal or external? Is it a mobility problem or a stability problem? And those are, I think, key for having a more targeted intervention, and you're going to be more effective in the long run. I'll give another clinical case on my end where I see a lot of times cervical spine is my jam. Like that's what I see a ton. And one of the things I love to do is manual therapy techniques, right? I love manipulations, mobilizations, all the above. And a lot of times doing some sort of a manual technique for these patients is going to be helpful. It's going to decrease their pain. It's going to help range of motion. It's going to help fire things better, get the muscles firing more efficiently. You'll see the biggest difference is what does that follow-up look like? And that's where I think we can sometimes miss the mark and not have as effective treatment, because if somebody has an actual mobility issue, or sorry, a stability issue, so you're looking at their range of motion and they're looking to the right and sitting, they have 45 degrees of rotation to the right. And then you have them lying down and passively you start to turn them and they're like, oh, you've got like 80 degrees. You have almost a full movement of the cervical spine. They probably don't have a mobility issue at that point. So you have to look and compare those active versus passive, contractile, non-contractile tissues. And my follow-up is going to look drastically different. I might still do some sort of a manipulation to maybe decrease the pain or get more effective muscle firing, but I'm not really interested in trying to improve mobility at this point. I'm trying to get them to control it better. So I'm going to do a lot more scapular control, maybe some isometric in the cervical spine if it's more painful, some resisted motions into that range to try and kick in the muscles to create a little more stability and access that range now. So the follow-up is really big for me, especially if I'm doing some manual techniques, whether it be for pain or for mobility. What am I going to do to follow up, which is the key thing. And I have to know what my goal is before that and what those impairments are.
Yeah, I love thinking through that. I don't know if you guys have noticed this before, but sometimes I'll get into a thought process around with low back. It's really easy for me to look at low back pain and kind of associate these things that you guys are talking about. Obviously, I'm looking at different types of tissues. I'm not quite as concerned about the imaging. But, when it comes to hip, to shoulder, even sometimes the neck, I sometimes forget about that still comes into play. And then like you're talking about, I really appreciated I'm treating one thing early on, but obviously as we work into it, I need to be reassessing and seeing what it is the patient needs as much right now. Is it more mobility now? Is it re-education into that mobility that I got? So that doesn't just happen in the first 2 or 3 sessions and then we strengthen. Like we got to keep reassessing and looking at that too. So very cool. Lucas, how about you? Any thoughts?
For the younger clinicians that are watching us, the suggestion here is simple: is to take a step back and ask yourself the questions you want to collect answers first. Contractile, non-contractile, intra-articular, extra-articular. This is not rocket science. It's out there. It's been out there for decades, right? Unfortunately, it's not taught in school, at least not to my knowledge. And that can lead to both cases that Mark and Drew shared here. Recently, I had a shoulder pain that was very painful to go into flexion actively. Passive was 90% better. The initial thought is contractile tissue, right there. But I wanted to check the cervical. I performed a distraction in seated, distraction of the cervical spine, and had the patient do a flexion of the shoulder again. At that point, it was painless. Right? So that is to emphasize that contractile, non-contractile, intra-articular, extra-articular is important. But to throw another layer there, always checking 2 joints above, 2 joints below.
I think that it sounds really easy sometimes of like, oh yeah, you just look at active versus passive. But when you start adding pain on top of it, like Lucas said, like it can get somewhat confusing. That's where sometimes if you have multiple joints, I think of a patient I have right now where there's some like radiculopathy symptoms, and she also has some shoulder pain going on. And we start working on C-spine. I tend to bias more centrally, and let's clear some of that up. And that's getting better and better, but she still has the shoulder thing that's going on. And now that that's cleared up, I can get a little better picture of do I think there's some component of the shoulder. So in my mind, like I think now she's probably like 65% cervical and maybe 35% shoulder. And we have it calmed down now quite a bit, and I can get a little more specific with some of my testing too. So there are times when it's going to be maybe multiple things, and you have to use some clinical judgment. And the more experience you get with it, the more you'll recognize, oh, I think this may be one of the main things. I tend to be a little more biased centrally, peripherally versus distal, unless something really stands out that after you start getting that calmed down and they're making progress and they're getting better range, but there's still this one thing that isn't changing. Now you can get even a little more specific and say, let's kind of go back and retest. It's better than it was before, but it's still not here. And like now when I'm doing some more specific rotator cuff or some contractile tissue tests, like that starts to reproduce some of her pain specifically in her shoulder versus the stuff that was going in her neck and somewhat down her arm. So kind of clearing one thing at a time is another thing as you're looking through this that can be really important as well. You just got to find a place to start and test, treat, retest.
And work in sequence to what you want to address. Sometimes you can go you can't find exactly what you need to work on right away and have a dramatic improvement. But if you feel like you're in a ballpark, you start to peel off layers of the issue, the situation, but always following the same concept: contractile, non-contractile, intra-articular, extra-articular. Is this 2 joints above, 2 joints below? Then you follow this on and on and on to help with the younger clinicians there, bringing this on a body chart. Have this taking note on a body chart, and you keep taking notes of that, and you review that body chart. It takes a glance at your notes to figure out like, oh, I missed this and that.
Another thing I would say for the younger clinician that maybe doesn't have as much pattern recognition is take those treatments to completion. Like if you're doing some sort of intervention and it's 40% better, keep going. Go on, look at vigor, keep in that same area versus saying, that's a little bit better. I see this other thing and I'm going to go here now. Like take that to completion until they're maybe not getting any better from it, or you've cleared whatever impairment that is, but they still have some symptoms, and then go back and look. That'll help you become more effective and start recognize those clinical patterns as well.
Yeah, good stuff, guys. I think lots of good pearls there as we're looking, obviously making sure that your clinical diagnosis, your clinical work is going to match some of the other things that you're looking at. Lucas, appreciate the 2 joints above and below and really being able to look at that as well. Again, driving home the test, retest mindset, and lots of good pearls in there and things that we can tend to forget about. So appreciate the insights, fellas, and until next week.